Nos da bawb, croeso i'r cyfarfod heno. Hayley Thomas dwi, Prif Weithredwr Bwrdd Iechyd Addysgu Powys. Dwi'n ddiolchgar iawn i chi gyd am ymuno â ni heddiw. Bydd y gwebinar yn cynnwys cyflwyniad byr wrtha i a Kate Wright, cyfarwyddwr meddygol ein Bwrdd Iechyd, ac yna bydd yna gyfle i chi i ni ateb cwestiynau a chi gofyn cwestiynau. Cyn i ni ddechrau, dwi'n mynd i ofyn i'n cydweithiwr Adrian Osborne i roi cyflwyniad technegol byr. So evening everybody, thank you very much for joining us this evening to this session. I'm Hayley Thomas and I'm Chief Executive of Powys Teaching Health Board. As we are following the first webinar that was held last week, we're going to provide a very short presentation at the start between myself and Kate Wright, the Medical Director, because I recognise not everybody joining today's session will be aware of the proposed changes that we're putting forward, and there will be opportunity for you to ask questions. So before I start, could I ask Adrian just to give us a technical briefing? Thank you.
Thank you very much, Hayley. So firstly, I'd like to say that we've really received some helpful feedback after our first webinar last week. Thank you for those of you who are joining or watching again, and you'll experience just a number of changes that I'll explain during my introduction. So as before, today's webinar will be recorded so that people who aren't able to join us listening in live right now will be able to watch the webinar later. And we'll publish the video on our engagement website shortly. The web address is there at the bottom of your screens. You can already watch the video from our first webinar on 8th of August on that website, and we'll add a copy of the slides as well, as we recognise there's quite a bit of information on the slides to take in. Now, we're using Microsoft Teams for today's event. If you click the three dots on your screen, you will see language and speech options. Here you can switch on live captions to help you follow today's event. Please be aware that some of our presenters will speak in both Welsh and English, as Hayley did in her introduction. If they speak in Welsh, they will repeat what they have said in English, but if, for instance, you're using English language captions, then what you see in the live captions may not necessarily pick up Welsh speech and vice versa. As Hayley said, our webinar will begin with a short presentation, and then that will be followed by Q&A. And during today's session, there'll be two ways that you could ask a question. Firstly, if you would prefer to raise a question in writing, or if that's more appropriate to your communication needs, including if you'd like to ask a question anonymously, then you can use the Q&A button on your screen to post that question. And during the Q&A, I'll be able to use those questions to ask our panel for their responses. Today also we will activate the raise hand option so that you can ask a question in person. And so when we reach that Q&A section, I'll be inviting people with their hands raised to switch on their microphones, and you can also switch on your camera if you wish, in order to raise your own question. Now, we do want to have the opportunity to answer as many questions as possible, so when your name is called, we'll be able to switch on your microphone, and as you said, you can switch on your camera if you wish, but please be aware that that does mean that your voice and your camera would be included in the recording of the event today. So if you don't want that, then please use the Q&A panel instead, and I can pose the questions that are raised on your behalf. Now, if possible, do keep your question brief and do ask just one question, as we want to use this time to cover as much ground as we can possibly cover and to bring in as many people as possible. If you've raised your question and have another, then please do feel free to raise your hand again, and we'll be able to come back round to you later in the session. And please also don't include personal information within your question or your comment that you're not happy to include in the recording. As I said, this recording will be added to the website so that other people in Powys are able to watch it at a later date. After your question, the microphone will then be passed to our panel to respond, and then we'll move to the next person in the question list or to the next question in our Q&A panel. Now, we welcome questions in both English and Welsh. And again, please accept our apologies. We'll be having this webinar up till about 6:45. If we can't answer all of our questions raised today, we'll do our best to keep our engagement website updated. And we are in the process of arranging some future webinar dates as well. So thank you for that. And without further ado, I'll pass you back to Hayley Thomas.
Thank you, Adrian. And just for awareness for colleagues joining and members of the public joining this session, Carl Cooper, the chair of the Health Board, is also with us today, here to listen to the questions and comments that come through this session. So firstly, I wanted to start to update people about some changes we've taken to our engagement timetable and approach. As part of this process, we continuously review and update our approach based on feedback we receive and also important conversations with Llais, the National Citizens' Voice body. And listening and learning to this, we've revised our approach by adding an additional 2 further weeks to our engagement timetable. And now the engagement will continue until the end until the 8th of September, apologies, so that people have more time to respond. After the engagement period then ends, a report will be prepared to bring together the insights from the engagement work and the views that have been expressed, and that will be taken to a meeting of our full board. And that meeting we are currently trying to get diarised to take place in early October, and we will confirm the date of that as soon as we are able, and we'll be making sure that that is publicised widely around the opportunity to watch, and beforehand, if you've got any questions, to be able to raise that with the chair beforehand. That board meeting then will make the decision whether to implement the temporary changes we'll take you through now, and it will be based on reflections on what we've heard during this engagement period. I mentioned before that later also this autumn we want to continue to work with you and have a conversation about additional sort of learning that we find during the discussions here around temporary changes, but also to help us shape options for the future for a safe and sustainable range of health services in the county. Just wanted to start by just mentioning a couple of facts. As you may be aware, Powys Teaching Health Board is the health board that's responsible for providing and commissioning services for the population of Powys, and we have a number of challenges within the county to face which are similar to other areas across Wales and the UK, but particularly our rurality and the fact that we're sparsely populated. The most sparsely populated county in England and Wales brings with it a certain range of challenges. We've also got people in Powys living longer in good health than the average for Wales and the UK average, but we do have inequalities within the county, and we have particularly Powys is at the forefront of an increasingly older population, with, for example, 28% of our population being over 65 years of age. We also know 1/3 of our people live alone, and loneliness can be a really serious issue that increases ill health and is a key reason why people need to seek further help from not just the healthcare sector, but also the wider partners and the third sector. We know we have some major challenges. We know that waiting times for planned care increased during the COVID pandemic and still remain a challenge. People are also spending longer in hospital than we would like, and we have a national recruitment challenge across the NHS, but for us, particularly in Powys, that's exacerbated by our rurality. And these challenges also affect not just us, but all our partners, including social care and the third sector. I think the other issue to say is we've all faced in our personal and in public life increased cost of living and inflationary challenges which affect the way services are provided and how we access them. So given these challenges, the Health Board is facing significant financial pressure. increasing demand and some sustainability issues around workforce availability. So some financial facts for yourselves. We ended the financial year of 2022-23 with a financial deficit of 7 million. And whilst we did achieve our plan last year, this still meant we ended the year with a deficit of 12 million. And we are currently expecting that at the end of this financial year, 24-25, we'll be operating a financial deficit of 22.9 million. And there are a number of factors that are driving this. I've mentioned to you demand, increasing prices, inflation, and other costs. But the amount we are spending buying our healthcare services for you from neighbouring district general hospitals and other providers is increasing. And to give you a bit of a sense, that has increased by 36 million over the last 5 years. And the amount we need to also spend on agency staff to help keep services running, again, has substantially increased over the last 5 years by about 7 million. And the costs of providing continuing healthcare has also more than doubled, increasing by 16 million over the last 5 years. So some of those reasons demonstrate for us why the uplift in the funding we have received, that the increases are substantially higher. And despite the Health Board delivering savings on an annual basis, that still leaves us with a gap, and we need to reassure you that we've also been focusing year on year on reducing administrative and management costs as well. But despite all of that, we continue to be in a deficit position. And Welsh Government, we're still in active dialogue with Welsh Government regarding the need to make further plans to reduce our deficit position. And at that point, I'd like to hand over to Kate Wright, who will summarise the key changes we're proposing. Thanks.
Thank you very much, Hayley, and good evening, everybody. So there are two sort of broad themes of changes, and the first changes that we are making are temporary changes to the provision of our minor injury unit service. So from autumn 2024, we're proposing to temporarily change the opening hours. We expect these to be temporary, in place for 6 months, and during that time we'll be keeping them under very close review whilst planning for the longer term shape of the service. So the changes that are proposed are that Ystrad Gynllais and Welshpool will be unchanged. Brecon is currently open for 24 hours a day. That will change to 8 till 8, and Llandudno, which is currently open from 7 AM to midnight, will change to 8 till 8. So both Brecon and Llandudno will change to be the same opening hours as Welshpool. Could I have the next slide, please? Thank you. A bit of background to that. We have discovered that recently, when we're having to frequently change and at short notice close the units due to staffing shortages. So in the first part of this year, between January and May, we had to close urgently at last minute about 50 times, which is meaning that our service has not been reliable. What that will do is it will allow us to provide a reliable service. People will know that our service is open 8 to 8. It will be more reliable, and it will enable us to more efficiently run our service. We are using a significant amount of bank and agency staff, and it will allow us to decrease that significantly, which will help both in terms of quality and safety, but also obviously with finance as well. We've looked carefully at the impact of that. We know that our minor injuries units are seeing just 1 or 2 patients per night. It's 1 to 2 in Brecon and less than 1, about 0.9 per night in Llandud. We have looked at the impact. We know that very few patients that are seen overnight are redirected to district general hospitals. On average, 1 patient per week is redirected overnight, that's per week, to a district general hospital, and 2 patients per day are redirected during the daytime to a district general hospital. Next slide, please. So I think it's important to explain what our minor injury units do. The minor injuries are for exactly what they're described as: cuts and bruises, small burns, sprains, minor fractures. They're not for more significant injuries. They're not for things like chest pain, choking, blackout, blood loss, suspected stroke. I think one of the things we have discovered during our conversations, whilst we've been talking to people in the community, is that we've heard that we may need to do some more work describing more clearly what our minor injury units do and what they're for. Our minor injuries nurses, our EMPs, are trained to look after minor injuries and are very, very good at that. They're not trained to look after more general or to make decisions on more general issues, such as more general symptoms, and they're not trained to advise on that or indeed to triage them. So it's really important. And so in that respect, they're not providing any urgent or emergency service for anything other than a simple minor injury. And I think that's really, really important. It's really important that if people do have symptoms that are not clearly an injury, then they must dial 111 or 999 for advice. We have our Shrop Doc service, which runs out of hours. That will remain unchanged. They're aware of the changes, and we do not see that will have these changes will have any impact on them. Thank you. Next slide, please. So the second change is going to be changed to the inpatient wards. And again, these are temporary changes that we're proposing from autumn 2024 for a period of 6 months. And those changes are that Llanelli and Broncleys are going to be converting to ready-to-go home units, and Brecon and Newtown as centres for inpatient rehabilitation. All of the other wards in Powys will remain unchanged. The reasoning for this is many. We know at the moment that although we have excellent staff providing the very best service that they can, our system isn't as good or as efficient as it should be, and certainly as we would like it to be. We have very long lengths of stay on our ward, much longer than England and much longer than some of Wales. And we know that by having people on our wards for too long, people decondition, they become rapidly more unwell, they lose muscle function, they get infections in hospital. And also because the movement of patients through our beds and the discharge of patients home is slower than we want it to be, that means that people get stuck in hospitals out of county. So we have people who any 1 week will have about 10 people stuck in beds out of our county, unable to get back into Powys, which means that their families have very long distances to travel to see them. The knock-on effects of our not being able to move patients back into our beds means that we are preventing access for acute and emergency patients to the district general hospitals, and we are also so therefore reducing the likelihood of getting a timely 999 response. So the whole system is impacted by the flow through all of our beds in all of our hospitals across the whole of Wales, but as community hospitals is really, really important. We also know that we're using a lot of bank and agency staff, and that there is harm, nothing wrong with the staff themselves, but there is harm across the system that is well documented when there is a high use of bank and agency staff, and that is something, finance notwithstanding, that we need to work hard to redress. So if we are looking at the ready-to-go units, experience tells us that by cohorting patients who are ready to go home, who no longer have a medical need, that allows the teams to focus on their discharge, focus on keeping them independent and focusing on getting them home as quickly as possible. For the rehab wards, we know that in 2014 we moved our system a little so that we had we moved our stroke patients so that whilst we'd had them across the county, we moved them so that they would be focused onto 2 wards, and that improved the care and the outcomes for our stroke patients. We know though that there's opportunity for lots of other patient groups, such as patients that maybe have had a fractured hip, who have had a sudden deconditioning from a sudden illness. We know that at the moment, because of our therapists, our expert therapists are travelling around the county, we can't get them always to give the focus rehab that some people need. And so the purpose of the rehab wards is to really give high quality dedicated rehab to the people that need it most. Not to say that we won't be providing rehab in other hospitals, but there'll be a bigger focus on these sites. That will again not only improve outcome but improve arthro through the system and benefit everybody, which is really our main intent here. Thank you very much. Next slide, please. Thank you. And I think that's back to Hayley.
Sorry all, apologies, I didn't unmute myself. So alongside today's session, there is more information available about these temporary changes on our engagement website, and the address is there on your screen. So that brings us to the end of the very short presentation. I appreciate it's not as full as last week's, but I felt it was very important to move to questions from the audience, and I'll hand over to Adrian now.
Thank you very much, Hayley and Kate. Rebecca, if we're able to sort of pop your questions slide back on, that would be fantastic, just to pop that onto our screen. So now we're going to move into our question section of this, and if you've got the raise hand option there and would like to raise a question, please raise your hand and we'll invite you to do that yourself. If you haven't got the raised hand option or would prefer to raise your question privately, then please do use the Q&A option in order to do that. Now, at the moment, I can't yet see any raised hands, actually, apart from my own, just to show that the raise hand works. Great, I can see that we've got some hands raised now. So firstly, I've got Susan. So what I'm going to do is allow your microphone and allow your camera. And if you would like to, you should now be able to switch on your microphone and switch on your camera if you wish to ask your question to the panel. So if you've got a microphone button in front of you, that should now be enabled to enable you to switch on your microphone, Susan. I can't switch your microphone on remotely, but I have enabled it. Okay, we can't currently hear you if you are speaking. So what I'm going to do is just move on to our next person, which is North Ward Town, and allow your microphone and your camera. So North Ward Town, your microphone should now be enabled if you're able to switch your microphone on. Sorry that we seem to be having some technical problems at the moment. The microphone there should be enabled for you to ask a question if you wish. We'll just see if I can sort out these technical issues in the background and move to our next individual, which is Gareth Jones, if you'd like to ask a question. And it looks like you've managed to activate your microphone there.
Yeah, thank you, Adrian. My question is quite simple. At last week's meeting, I put a question in the question and answer session regarding requesting details of what the authorities charge for Powys patients attending out-of-county A&E or MIUs. Adrian gave a general response, but there wasn't a specific response around A&Es and MIUs and the cost of each patient attending.
Shall I come in there, Adrian?
That would be fantastic. Thank you, Kate.
Thank you. So, so for patients going into England, then we are not charged for emergency department or MIU attendances. We would only be charged if the patient was admitted to hospital. In Wales, it is much more complicated and much more difficult to decipher, given the way that, so we are charged in Wales for most health boards, but we've been unable to disaggregate the data in that the the way that the patients are coded means that full A&E, so major A&E and MIU charges are not disaggregated, and so it's very difficult. I don't have a sum for the Welsh figure, so it's free in England. There is a charge for the Welsh figure, but very difficult to give an overall figure, unfortunately.
So is that something that can be provided, the total number of patients who attend the Welsh A&E and MIUs and the total payments made for a year?
I can ask, but it's certainly the team have looked at it, and it's not, some figures are very easy to get and some are very difficult just purely because of the way other health boards code their figures. So I'm not completely confident of that, no.
All right. So I just thought you'd need that figure for your business case, that's all.
Yeah, I'd also, just in terms of activity, thanks for that question. We know for the financial year, last year, 23-24, there were 29,009 ED attendances out of county. It's quite difficult to know, as Kate described, the breakdown between major, minors, MIUs that go through there, but it's 29,009 that overall for the whole of Powys population last year.
And the cost?
Well, it's very hard to answer that, as Kate said, because of the way in which the contracting is different between England and Wales. So we have an overall cost that we have per provider that we track, but to actually put an overall figure on that isn't possible at this stage.
Thanks very much, Gareth. And what I'm going to do is I'll move to our next question so that we've got the opportunity to take as many as possible during today's session. So I'm just wondering whether either Susan or Northwood has been able to activate their microphones at all to ask your questions. If not, please do use the Q&A bar to do that. And in the meantime, then I'll activate the microphone for Steve Witherden. So your microphone should now be enabled, Steve, if you'd like to ask a question. Okay, that's showing as on, and apologies, I can't switch it on remotely for you. Is your microphone able to work for you there, Steve? Sorry about this. Now, I was hopeful that by changing the technology on the meeting today, we'd allow more opportunity for people to ask their questions in person, and I'm really sorry that the technology isn't quite working for us today. But if either Susan, Steve or Northwood are able to either access your microphones to switch those on, we'd be very happy to take your questions, or alternatively, please do pop those into the Q&A chat so we can ask you. And I can see Susan, so sorry you weren't able to enable your microphone. They say that the change is for 6 months, and that's across the autumn and winter months. What plans are there to assist people without transport or access to transport to attend MIU in a place away from their home? And what plans to assist single parents with more than one child to take the one child who needs care to an MIU? Kate, if you'd like to come in there.
Yeah, of course. So I should have said actually that again, the numbers of patients we know that this would affect will be tiny, in that it's 1 per 2 per night. But also I didn't mention that we also have a phone first policy, so that, and there will be clear, as there is in Welshpool and the sites that are currently not open overnight, we'll have clear messaging so that people will be able to access the minor injury service in Powys the following day. So it's anticipated that nobody will need to travel unnecessarily overnight. We know that minor injuries by their very nature don't need to be seen immediately and can safely wait. So we anticipate that they would be seen promptly the following day, and that only patients that would currently actually need to attend an ED due to the nature of their injury would need to travel overnight, which they would have needed to do anyway. We know that just making sure I get my information right. I'm just going to check. We do have the information for the number of people that are redirected. I'll just check that and I can tell you in a minute.
Thanks. So yes, I do remember you mentioned that briefly in the presentation earlier. Just checking with our questioners. So that was the question from Susan, who unfortunately wasn't able to activate her mic. And it looks like, sadly, Steve and Northwood Town haven't been able to do so either. If you are able to use the Q&A panel in order to post your question, then please do, and I'll be happy to raise those questions on your behalf. Gareth, I know that you've posted another couple of questions there. So, for instance, can we provide the split of the 50 plus closures across the individual MIUs? And during the period that Kate was referring to, there were 10 overnight closures and 40 at Llandrindod Wells. And just by way of example, this week there have been 2 overnight closures and also 2 early closures at Brecon and 2 early closures at Llandrindod Wells. So in terms of just other questions that are coming in as well, again, if any of those colleagues that have had their microphones enabled do want to come in with a question, please do. In the meantime, I'll continue to take questions from the panel, and including questions that we weren't able to answer last week. And I wonder whether this is one that I think we have Paul Buss on the call as well, whether you might be able to talk to us a little bit about the evidence base in relation to decommissioning. As I understand, that's been a key element of the case for change in relation to the ready to go home units and the need for change in our inpatient wards. Paul, would you like to come in on that?
Yes, can you hear me now?
I can hear you now. I
Okay.
can see that your microphone's on. Thank you very much, Paul.
Thank you so much for the question, and thanks for bringing me in, Adrian. Yes, you know, the overall position with regards to deconditioning has been a long-standing question, I think, for the last 15 years in healthcare. As we've got older as a population, people have started to realise that deconditioning in hospital is a major hospital-acquired condition. It's a bit like hospital-acquired infections. It's starting to get really to the top of the tree where people are really realizing that deconditioning is very real. And any clinician who's been on wards that have older patients recognize what they see with their eyes and their ears, and those with patients closest to them. When patients are on wards for lengths of time, even after the first week, they become weaker. They can often become disorientated and their cognitive capabilities decline. And there's good evidence that cardiovascular and respiratory function also decline. And so we were aware of that when we actually started to look at these cases, to be honest. I mean, it was really a fundamental element of this. What it was is that back in 2017, just before COVID, the British Geriatric Society they produced a national approach to raising awareness on deconditioning, because it was such a fundamental problem and directly related to length of stay. The longer you stayed in hospital, the longer your loved one was more likely to become less independent and suffer the consequences of that stay in hospital. So they started their national awareness campaign then, and you can find that online. And since then, a whole series of players. So you'll find papers in the BMJ, including from the World Health Organization, saying that there's a really big issue in relation to deconditioning. There have been local studies in Wales, which we are aware of, that have shown increased risk of infections in hospital due to length of stay, but also increased morbidity and mortality in patients with the longest length of stays. And the ones that were game changers, I think, for me in recent years in this piece of work was, first of all, the Health Foundation last year produced a really super report on length of stay in hospitals in England and Wales. And its very first point, the very first bullet point was avoid length of stays being long because of infections and because of deconditioning. And for me, I always look at the Welsh literature to try and sort of get a local context. And Age Cymru produced a fact sheet in December 2023, focusing on length of stay. And goal 6 in that fact sheet is please avoid long stays in hospital because of deconditioning. So I think for all these things in the round, they convinced us that with Powys having a long length of stay compared with the rest of Wales, and Wales having a longer length of stay than England, we really should do something about it urgently. And it was important, therefore, that, temporary service change seemed to be the right channel, because we needed to do this in the right manner, in the right way, for the right reasons.
Thanks very much, Paul. And I think what will be helpful, we can share some of those links on our FAQs on our website and through other channels to enable people to look into that in a little bit more detail. And my sincere apologies that we've just been having some technical issues with the microphones. Please do continue to use the Q&A panel. If any of the colleagues with their hands up are able to activate their microphones at all. Rafe Devlin, I don't know if you want to try now to see if your microphone will work, as I can see that your hand's up as well. That should be enabled for you if you can see a button on your screen to enable that microphone to be switched on so that you can ask your question. And with apologies, that still doesn't seem to be working. So I'm going to go back to the questions that we've had in the Q&A panel.
Adrian.
Oh, hello.
It's Gareth.
Oh, fantastic, yeah.
Is the issue because you haven't disabled my mic?
No, or any active mics should be enabled at the moment, and recognise that you've posted some other questions, so very happy to bring you in there, Gareth, as your microphone is working, if there's another question that you'd like to raise.
Not at this moment. I just going to say I need to disappear in 5 minutes. I got another meeting to go to, but.
Okay, well, thanks very much for joining us, and very, very glad that your microphone was able to work. In terms of some of the other questions that we have in the chat bar, so I'm just trying to work through these. And maybe, Kate, if I can come to you on this one in the first instance. So Susan has asked, are there any plans by the Health Board to approach the government for funding to have our own county hospital, our own district general hospital within Powys, rather than for paying to travel outside of the hospital for care?
Yeah, thank you very much for that question, Susan. So I think the short answer is no, and I will explain why. So there were several reasons that having our own district general hospital would be, well, not even difficult, but impossible to have a safe and effective and sustainable hospital. Our geography is very challenging. We wouldn't really have any obvious place to put it that would be convenient for people, especially given our spread of population. What we know so district general hospitals provide urgent and planned care, but often focused on urgent care, and patients would naturally flow or naturally go to their nearest acute care provider, which for many of our patients would be in other surrounding DGHs and hospitals. So that would mean if we were able to have and staff a district general hospital, wherever we were to put it, it's still likely that a significant proportion of our population would go to a different facility. In terms of what's needed for a district general hospital, then an emergency department is needed. And to support the emergency department, there's several key specialties which are pretty essential for that to happen. And that is general surgery, general medicine, maternity, paediatrics, anaesthetists, anaesthetics, to name but a few. And what we know is that for that system to work safely, then each of those systems, each of those specialties has to be strong and robust. We know that even when we were in easier times, when staffing was easier, that it would have been very, very challenging to staff an additional district general hospital. But in the current climate, there is absolutely no prospect of us being able to safely and reliably staff a district general hospital. And I think the important thing is, again, it comes down to the emergency flows. We know that in terms of outcomes, then patients are better. If we were to have one, it would be a very small centre. We know that patients in general for many conditions are better seen in big centres where staff are seeing a high volume of patients, so they have the clinical expertise and have the exposure to lots of patients. If we were to even try and have a district general hospital, it would be very small indeed, would be unlikely to attract the staff to work in it, and would unlikely to have the volume of work that would mean that the staff could upkeep their skills. So those are a few of the reasons. That doesn't mean that we're not ambitious. That doesn't mean that we can't provide urgent care in Powys. We absolutely do, and we have ambition to do more, but we have to do it in a safe and sustainable way, which would look more bespoke and more innovative. And that is work that is ongoing. So our GPs are brilliant and provide a lot of urgent care very, very well, actually. And we've got the minor injuries at the moment are only trained to look at minor injuries. We'd have ambition for them to see more, but again, in order to do that, we need to consolidate and get ourselves to a position where we have a reliable service with our cohort staff that are not agency, so that we have the confidence and our own staff base to build on. So we have ambition to do more, but it can't be in the District General Hospital.
Thanks, Kate. That's a helpful response. And obviously all of those issues about 24-hour radiology, diagnostics, labs, all of those kind of things that are absolutely vital, that when you've got that A&E open door, it needs to have all of that infrastructure sitting behind that front door in order to be able to diagnose all of those different conditions and provide timely life-saving treatment, doesn't it? Otherwise, it's best to get straight to that centre that's got all of that skills and experience in one place, rather than having too many stops on the way before we get there. Now, there's a number of other questions coming into the chat, and if I can try and bring a few together. So how is it that we actually feel that changing the beds in these ways is actually going to reduce length of stay for patients? How does that make sense, I guess, is the core question. And also linked to that, recognising that some of the challenges in social care are a problem as well. How on earth do we get those solved? How are we working with the local authority to try and make sure that the social care infrastructure is right? So maybe, Kate, if I can ask you first about that model of care issue. Hayley, perhaps if you're happy to come in relation to social care.
Yeah, thank you for that question. So again, what we know is that at the moment we have patients with mixed needs across all of our wards, geographically apart. Although, you know, some of our hospitals are pretty close together, we still have staff who are travelling between hospitals to give specialist care, for example, specialist rehab. We know that we're not always meeting our targets and the standards for stroke care because our specialist therapists are spread too thinly. So we know that by cohorting and trying to reduce the amount of travel for the staff, then we will be able to provide a much better active rehab offer for the patients that need it most. We know that we have our discharge teams and staff that are very experienced in, and discharge is a specialty, and discharge, you know, there are great skills to facilitate patients' independence and early discharge. But at the moment, our staff, both social services staff and health board staff, are spread very, very thinly. So by cohorting them onto wards where they become centres of excellence and expertise, then those teams can work really closely together much more effectively than they're currently able to. So at the moment, we've got staff really working very hard and doing the best they can, but the system around them isn't supporting them to produce the outcomes that we need. So we have, you know, there is evidence from elsewhere that this helps and this has worked. And this is, you know, this is what we believe will, and we've shown in the past by cohorting our stroke patients, we believe that this will deliver what we want, but obviously we'll need to watch very carefully and we'll be learning as we go.
Thanks, Kate. And before I go over to Hayley there, just another maybe slightly more practical question about that is, as part of those proposals, do you anticipate seeing patients moving multiple times within hospitals within Powys, or will this mostly apply to new patients either being admitted locally or stepping down from district general hospital care?
Yeah, thank you, Adrian, and that's a really important question. And I know that is a worry for some people. So the intention is not to start moving people around the county. That we're going to avoid that wherever we can. This would be wherever possible a planned move into the right bed from the very beginning, so that we can get people into that purposeful bed straight away. As we said earlier, we've got people currently travelling long distances and getting stuck out of county. We also have looked at the way we have arranged this so that it's not anticipated that we would place people significantly out of area. They would be placed into another hospital that was close by. And so the hope is, and our hope is, that we're not having people travelling excessively. In fact, it's possible they'll be travelling less than they currently have to if we can improve the inter-county position.
Thanks. Now, I'm conscious that we're keeping people later than we planned, but there's a couple of great questions come in. So if maybe we're able to carry on for a few more minutes. And so, Hayley, on that social care issue that's been raised, how do we address the issues of social care capacity and infrastructure to help make sure that patients are in the right place at the right time?
Yeah, thank you, Adrian, and a really good question. The first thing to say, we work very closely with our social care colleagues in Powys and the third sector in developing our thinking around this. What is clear at the moment is the system is under tremendous pressure, the whole system, and we're unable currently to bring our patients out of hospital when we would like. So giving you a bit of a sense of that, you know, between April and July, I think we lost nearly, 2,700 days of delays just in our Powys community sort of hospitals. And the reality is this is about testing a new way of working, which is part of the reason why it's temporary, the ready to go home unit. We're wanting to work really closely with our social care colleagues and the third sector to ensure that that complete focus on reablement, getting people out of hospital as quickly as possible and home will actually have an impact. And we can only really properly test that by doing it and evaluating it. And so we've been working very closely with our social care colleagues to make sure that they are working alongside us to ensure that we're testing this new model out properly over the next 6 months to see whether it's having the impact we're looking for. And for me, the length of stay, and back to that, and Paul Bus may choose to want to come in on this, reducing length of stay, there will be a direct correlation with the ongoing care needs potentially for these patients, dependent on how quickly we can get them home. So really important work with social care.
Thanks. So I'll bring in Paul there, and just in order for us to be able to bring this to a timely conclusion, I'm going to go through another few questions at a very quick fire pace. So if we're able to look at just 2 or 3 sentence answers wherever possible. So Paul, length of stay.
Yeah, just wanted to come back on that. Thanks very much, Adrian. In essence, there's a self-fulfilling system at the moment, isn't there, really? Someone with more straightforward condition on a unit who would be considered a simple discharge rather than a complex one can decondition on a ward where there's a mixture of patients. And by definition, then, that will increase their length of stay. But if we have a medically fit for discharge patient who can access one of these wards or one of these units, the ready to go unit is focusing on maintaining their independence. And so that makes them more likely also not only to go home more quickly, but to go home on a lower state of dependence. And I think that's a win for us and a win for social care. So that's the desire for us, that we're actually going to get those kind of benefits. But as Hayley says, we have to evaluate them, but they're based on evidence and they're based on also our experience.
Thank you very much, Paul. Now, a couple of quick fire ones here. I wonder if Steve Powell would be happy to come in on this. We've had a number of questions about kind of carers and travel and support and time, maybe less directly related to these particularly temporary changes. But Councillor Sandra Davies is saying, I met with a group of people this afternoon. They raised a number of concerns, problems for carers whose loved ones have anxiety going to hospital for a procedure. If they do not attend after 2 appointments, they are crossed off. What help and support is there for carers? So Steve, are you happy to come in on that?
Yes, thank you, and good evening, everyone. Steve Powell, Director of Planning Performance at the Health Board, and thank you, Councillor, for that question. So, having read that question, I believe this is more around planned care and outpatient attendances and those appointments that are scheduled in conjunction with the patient. So many providers, including ourselves, will have what's known as an access policy that stipulates what fair and reasonable means to both the provider and the patient when booking and scheduling appointments. So a patient should be at least offered at least 2 appointment dates for either outpatient attendance or elective procedure. And then there's that negotiation around if that's suitable, and if not, when can the next suitable date be undertaken. Clearly, resources are finite in the NHS, and that dialogue cannot go on indefinitely. So as I say, the access policies are developed to ensure that happens. Similarly, at the other end of the pathway, if people do not attend their attendances, there's a process by which the provider and the patient will work to see why didn't they attend, when can they come back for rebook. But as a routine, patients are not removed from waiting lists because they either fail to attend or would not agree to appointment. That's done in dialogue with the patient and with the patient's GP. So hopefully that provides some reassurance. And apologies, Adrian, a bit longer answer than a couple of sentences, but a complex question to respond to.
Thank you, Steve. I'm going to come to Hayley next. A couple of questions about the temporary nature of these proposals. You've said they're temporary. How can people have confidence that they are temporary? What does that mean?
So what it means is we've got to find different ways of working and testing them out and making sure that they're having the right positive impact we're expecting based on the evidence that Kate and Paul have just referenced earlier in some of the responses. I was asked directly in the board, so what happens if you're not getting the impact and you think that it's not making things better? And I've been able to say to people, we would be constantly reviewing this, and if that happens, then we could reverse that decision. We're not changing, closing sites, you know, the beds will still be there. It will just be about a different decision about which patients go into those beds going forward. I genuinely don't know the evaluation. Everything is telling me that it will be beneficial, impactful, and really positive, but we do need to evaluate it properly. And if in the case that the board then feels, because it will be monitoring our progress against this, that it is not having the impact that we're looking for, then the decision would be able to be taken to stop it and think again and to test other ways of working. What I would say though, Adrian, is we've got to find a way of unlocking this and getting the improvement in place. And I think it'll be a process of continuous improvement. And I would expect the board will be informed if there is any changes that we would need to put in place because we're not getting the expected benefits from the change. So I just want to reassure people that that's part of the reason why this is temporary, is to test and make sure that it works for a rural setting. We know the evidence base is there, but we need to make sure it works in Powys.
Thanks, Hayley. And I think that also stresses one of the importance of the engagement process for people to share their views, because the issues that people are raising with us, including through sessions like this evening, are helping to identify exactly those sort of measures that we should be looking at to ensure that benefits are being delivered, but also to monitor whether there are unintended consequences as well, so that the Health Board can monitor these appropriately and effectively and make the right and best decisions about temporary nature. And as part of that engagement, people are asking how people can get involved if they're not able to attend online. Just to reinforce that anybody can request a printed copy of our engagement materials to be sent to their home address. So 01874 442 078. That's 01874 442 078. We've got an answering phone service there where you can just leave a message with your name and address and spell any unusual words, and that will get a copy of the engagement document sent direct to your home so that you can read that at your leisure and then also feedback your views. Just one final comment, and I recognise we haven't quite managed to cover everything, but one of the people who had put their hand up and have not yet managed to reach their question was North Ward Town Councillor, and that's Councillor Jamie Jones. And bluntly, he's saying all we seem to be seeing is cuts on cuts on cuts, with services declining. He himself has been sent out of Powys to England for treatment and felt like a second-class patient because they were Welsh. We're talking about the benefits from these changes, yet it does feel like more cuts. So how do I, as a town councillor, explain that we have to suffer yet more cuts in an area that already feels like a desert? Hayley, I wonder if you're happy to come in on that difficult question there.
That is a difficult question, and I'm sorry to hear about the experience of feeling a second-class citizen in terms of the access to services. I would welcome, when these issues are coming up, I would welcome the feedback, because we have a commissioning arrangement with our services cross-border into England, and we have clear requirements that they treat the patients as they treat all patients in terms of clinical prioritisation and the approach that they take. So if colleagues would like to share some of that information, we can look into that. But we, in terms of the activity, etc., that we're seeing, we're expecting all of our patients in Powys to have the same level of service as those from other parts of Wales or other parts of England. With regard to the point about cuts, so I think the reality is the financial position facing all public sector services currently is a very serious one, and therefore we've got to look at how can we do what we can do for the best means within our means and get the best productivity and efficiency from the resources that we have. Our job in the Health Board at the moment is to make plans to live within our means, and clearly that is important that we have that conversation with the general public. And I want to just again talk very openly with the public that what we're trying to do here is test some thoughts around temporary changes that helps us build potential options for the future about how we can be more sustainable. And I think that's across the whole system of public sector delivery in Powys. And I do appreciate that the concerns being raised by the communities, but our job is to actually work within the budget that we're currently given. And that's why we will need to have serious conversations with the public about the options for the future. And there will be difficult decisions ahead. I don't think I should shy away from saying that to colleagues. So, yeah. So in the autumn, we'll be starting that work with the public, conversation about the future permanent arrangements around services so that they remain to be there to serve the people of Powys for the future. Thanks.
Thanks, Hayley, there for your frankness and openness. Not an easy message to say or to hear, but an important one, particularly given all of those challenges across the public sector right now. I think I really do need to bring today's session to a close now. As I said, we will be advertising some further sessions. Sincere apologies around the microphone issues, that people weren't able to switch their microphones on today, despite our best intentions, but we were able to bring many of those questions out from the Q&A panel. I wonder now if I could ask Carl Cooper, our chair, for some closing remarks, and particularly to reflect on the board's role now in keeping these changes under review and that transparency and openness with the public.
Thank you, Adrian. Dwi eisiau just cychwyn trwy fynegu diolch I bob un sydd wedi paratoi ar gyfer y gweminar yma heno, a phob un wrth gwrs sydd wedi cyfrannu mewn unrhyw ffordd at drafodaeth, at y cwestiynau a'r atebion. I've really appreciated the opportunity to be here in this session to listen and to learn from everything that's been said by all who have participated. As chair of the board, I have a responsibility to lead the board That's the body that will ultimately take final decisions. We have a number of different accountabilities placed upon us, but one of our most important accountabilities is to the population, to the people that we serve. And so it's really good to have people in this conversation today, and indeed involved in other opportunities, because we need to make sure that as a board, we are listening and learning as much as possible. And so thank you to all. But of course, the conversation, the engagement isn't the end, it's a means to an end. And the purpose of today and of the whole engagement process is to make sure that the decisions that we ultimately make are fully informed and in the service of our population. Of course, meeting the requirements placed upon us and fulfilling the duties placed upon us. And so, as Hayley started by saying, a report will come to subsequent meetings of our board. We will scrutinise those reports to ensure that full conscientious consideration is given to everything that we have heard and that we have learnt from our engagement with yourselves. And certainly I want to give that assurance to the population of Powys. So it's good to be here today, and I also look forward to being involved in other conversations and in other discussions. Thank you.
Thank you very much. That brings today's session to a close. So the recording will stop, and we will make sure that